part of my instruction course, and I thank you, sir, from the bottom of my heart, and I have no words to thank you.
Thank you, Devang, for including me into the program. In fact, it's always a pleasure to interact with the AIMS people. They're kind of a sister institution, so we always look forward to collaborate. I'll be talking about the selected laser trabeculoplasty, or SLT. SLT basically treats the angle with low energy laser, and as you can see in the anatomy, so you have the trabecular meshwork. So prerequisite for SLT is that you should be able to see the trabecular meshwork, and at least 180 degrees, if not more than that. But in open angle glaucoma or ocular hypertension, where the laser is usually done, you have open angles. And this is a frequency double YAG laser 532, and the duration is very short, only in like 3 nanoseconds. But the spot size is larger, so you can, you can irradiate the whole of the width of the angle in one go. So you will put confluent spots at least 180 degrees or 360 degrees, and it will be like about 50 spots per half. So you could go up to, if you're treating 360 degrees, you could go up to like 100 spots on an average. And also you start with a little energy somewhere around 0.7, 0.8 millijoules, and look at the end point. When you apply laser to detect meshwork, you will see a slight bubble there. So that and you can reduce the energy a little bit, so that you are somewhere where you just get the bubble formation with the laser energy. SLT has been used in many studies now, and in fact from its first description by Letton et al. And there's enough data to suggest that laser iodotomy it effective in reducing intraocular pressure. And we are now using SLT as a primary therapy more and more. And this is just to quote one of the studies where ocular hypertension and POAG patients, they were treated with the SLT and also the medical treatment, and they were it's a randomized trial where they compared, and they found that SLT was like up to 31% IOP reduction in this study, and SLT basically meant that it's equivalent to latanoprost and lasted in this study at least for 12 months. So you can say that you could replace latanoprost or one drug for 12 months. So that's a very good results as far as IOP lowering is concerned. More data is available on primary SLT as well, and this is another study from Chinese population, from Eastern population basically, where this is again a randomized trial where you have a laser group and a medicine group, and there was the follow was longer here, about 5 years follow-up, and they almost did similar, both the groups did similar as far as IOP control was concerned over a period of 5 years. So that means that laser therapy does work in eyes when it's done as a primary procedure in ocular hypertension and POAG patients. Another thing about SLT is that in glaucoma we need IOP lowering which is sustained. We don't want to have IOP fluctuations. And the problem with medicines is that the IOP can still fluctuate, and especially if you miss a drop, which is quite common. So SLT has that advantage that it gives you a persistently a stable intraocular pressure over 24 hours period, and especially in this study, this was found to be useful, particularly for NTG patients as well. So currently there's increasingly becoming treatment of choice for ocular hypertension, POAG, and even some of the secondary open angle glaucoma patients. Not many people prefer this in India because this kind of a little belief that maybe whether this really works in our eyes or not. So we did a couple of trials. Basically, both are the prospective trials. One was the non-randomized, where we treated patients who were already on medical therapy, and we gave SLT to them. And also there was a prospective randomized trial was done, and that was in relation to angle closure glaucoma. So I'll just share some data on these trials with you. So this was the open angle group. Now these are the eyes who were already on multiple medical therapies, and we wanted a little extra lowering IOP, so we thought before surgery, let's try SLT for these patients. And as you can see, majority are POAG patients, but there were some other groups as well. Now, this chart, as you can see, it suggests that SLT did bring down the pressures significantly at all the time intervals up to 1 year. And even at 1 year, from 23 or 24 millimeters of mercury baseline, it came down to 16 or 17 millimeters of mercury baseline. So that's kind of a significant reduction in IOP at all the time points. And these were patients who were otherwise difficult to, we had difficulty in controlling intraocular pressure. This is just one example of 28 years old female who had a POAG, moderately advanced glaucoma, and was on multiple drugs, and pressure was not very well controlled. So we did laser SLT, and at that point of time, the right eye IOP was 30 millimeters of mercury, and you can see the subsequent line. It's come down to almost around 20 millimeters of mercury. For almost 2 years, the pressure was very stable. And then she underwent cataract surgery, and which actually upset her pressures again. So we had difficulty in controlling pressure. So this is another example. This was POAG, again, moderate disease. Starting pressures were like 30 millimeters of mercury, and you can see after laser, the IOP fluctuated a little bit for a couple of weeks, but then it stabilized, and which remains good for another 20 months before it started wearing again. So that was the time probably the effect of SLT was waning off in these patients. And if you can see in this study, we had a IOP reduction, significant IOP reduction at all time point, at least up to 6 months to 1 year. We didn't have any complications here. 3 patients didn't respond. The IOP, the SLT didn't do any reduction in IOP in these patients. In one patient, paradoxically, the IOP actually went up after SLT. And apart from that, we didn't have any complications during this period of time. Another study we conducted was on angle closure glaucoma. Now, this was, again, a prospective cross-sectional randomized trial. But here we did the laser iodotomy first, and if the pressure was still high after laser iodotomy, like PAC or early PACG group, PAC mostly, these were patients. So after laser iodotomy, the pressure, the precondition was that the angle should be visible for at least 180 degrees, and then we did the laser iodotomy for these patients. And you can see all these patients, up to 1 year, they had a significant IOP reduction, even in angle closure glaucoma following selective laser trabeculoplasty. So SLT has many advantages. It could be used in different kind of glaucoma, can be used there: OHD, POAG, NTG, pseudoexfoliation glaucoma, steroid-induced glaucoma, pigmentary glaucoma, and as you have just seen, even some cases of angle closure disease can be treated with SLT. And also, it's very convenient to use, so no drug-related side effects would be there. So you can get rid of at least some of the drugs, ocular or systemic. And the compliance is not an issue because you have given the SLT is going to, if it works, it's going to work for a couple of years at least. The cost of treatment and availability could be an issue because it's not available at all places. So the cost of SLT is roughly equal to about, 1 drop of latanoprost for 1 year, but this could vary in different countries and in different regions. So to summarize, SLT lowers IOP in OAG as well as in angle closure glaucoma, even in our population. IOP lowering is comparable with the published data, and this we didn't see any vision-threatening complications, and it has many advantages. Thank you very much.
Thank you, sir, for such a wonderful talk. Any questions from the audience? Yes, Neha?
No, I mean, if we are doing a primary therapy, then obviously the patient is not on any treatment, so SLT is the first choice. But if the patient is already on anti-glaucoma medicines, we don't stop anti-glaucoma medicines, because most of these patients, we are doing SLT because we are not happy with medicines. That in terms of IOP control. But if you are doing SLT and the problem with the medicine is because of the side effects, like patient is not tolerating the medicine, or you're getting side effects, ocular surface or otherwise, then definitely you have to stop the medicine and do SLT and stop the medicine.
Do you feel there's any difference in efficacy if you are doing SLT as a primary thing, or you are doing when the patient is already
Yeah,
on
that is what is kind of mentioned in literature also. We haven't done any trial on our own,
your
but
experience,
yes,
just
but it does seem to work better if you offer as a primary therapy. Yeah. And also because some of these studies, the IOP lowering is kind of also a function of the initial IOP. So when you're doing primary therapy and the pressure is high, so SLTs will do the maximum work there. And if the IOP is already reduced by medicine to some extent, and then you're doing SLT, then obviously the effect seen would be a little less. So it could be that way also. So whether it's truly SLT is better in primary or not, then that you can debate that. But generally, it is preferred that SLT would be a good
And
choice.
in how many percentage of patients you feel that you had the need to repeat the
SLT.
Don't have the data offhand, but it does last to 2 to 3 years as in our patients, in our own patients.
Thank you, sir.
So I have a question. In the open angle study, do you do it for primary open angles, or you even included secondary
I think there were mixed patients.
mixed
in that
patients?
study, yeah.
That is in PACG as well.
Yeah, that was
Mixed patients in
yeah,
PACG.
not angle closure, but
Okay. So
like
they were
pseudo-exfoliation
primary-
pigmentary,
Okay,
POAG, or
okay.
even some NTG.
And
also.
angle closure, they were primary angle closures.
They were primary angle closure.
So after PI, in which you think they were not medically controlled, you gave a
yeah,
trial of
if the
SLT.
eye pressure is still high, you have an option of, and if you can see the angle at least
And-
180 degrees, you have an option of doing SLT.
And you think it was equally effective as open
Yes,
angles?
Yes. It's not a comparative trial between
Yeah,
angle
yeah,
closure and
but-
open angle, but going by the effect size,
Yes.
I think they're more or less similar.
Okay.
So
Any
I
other
have a
question?
question. Have you tried in PACG patient after cataract surgery when the means you have done after PI when the angle is open after cataract surgery when the TM is visible? Have
No,
you
this
tried
was
that?
before cataract surgery.
These
No,
were primary
This was
patients.
just angle closure glaucoma,
After.
and we did laser iodotomy, and then.
Can we do in
cases.
pseudophakic PACG?
Probably you could
easier.
do it, but I think in angle closure, cataract surgery itself brings down the pressure, I think, quite significantly. So,
Okay.
so
Thank you,
if
sir.
pressure is still high, you still have that option, but we haven't, we didn't try that actually.
So SLT in our center, because it's a government center, it's not it's free of cost. So your place
Yeah,
also
it's free of cost. So our
to
patient
us.
actually has that advantage because you just one time it works, it works for a couple of years at least. Bill, do you use SLT? Do you? So,
I think I probably should use it more for primary treatment actually. We're still a bit old-fashioned in the sense of tending to use drops initially, but as Surinder's saying, there's more and more evidence that it seems to be equivalent to drops, and also the compliance is obviously not an issue. A very nice talk, Surinder. Thanks very much.
Thank you. I think compliance is a big issue. I think in all populations and more so with ours, I believe. So, if SLT works for a particular patient, I think there's
Sir,
a
about
merit in using that.
long-term results of SLT, do you think there is increased incidence of pigment shedding and sometimes leading to secondary angle closure in some patients?
I don't think so, because if you have done the procedure correctly, I think if you have done only the tapered mesh work, so I don't think so. Corneal endothelial loss has been a little concern, but probably not much of an issue.
So I just want to add, sir, one more thing, that in our center we have particularly seen the advantage of SLT in post-vitrectomized eyes patients, wherein vitrectomy has been done and they are waiting for the second procedure, maybe for the oil to be removed, or we are waiting for the conjunctiva to heal. That time we have used SLT and it has markedly reduced the vision in such patients, the IOP in such patients, and it was actually a good means to control the IOP in these patients.
We haven't tried for post vitrectomy or post RD surgery eyes because they tend to be intractable. They're difficult to, especially if you have a silicone in the eye. So I have no experience on that, but I did try for a couple of juvenile glaucoma patients where I didn't expect it to work actually, but because the patient was such that he didn't want to go for surgery and the pressure was going really high. And he had his exams actually, so he wanted to do after the exam. So I thought, okay, I'll just try the SLT. It did bring down the pressure for a couple of weeks, so gave us that time to do the surgery. So even though it was not really expected to work that well, but it did bring down the pressure to a comfortable level for a couple of weeks.
How long did it last, sir?
I think we did his surgery after his
Just
abscess,
his
so
abscess,
about a
okay.
month or so.
Okay,
So.
okay.
I was really interested to see your results with the angle closure, because we don't get enough angle closures
Yeah.
to do this sort of trial,
Yeah.
and they're very nice actually. I'd often wonder.
Yeah, I think Bill, that has been published. I think. Just see. I'll give you that. I think that data sometime. Where is that? There's the publication there.
Oh,
Okay,
it's not showing on
showing.
screen.
But I think this is in the I journal. Yeah. So yeah, it's 1918. So this, yeah. So I think I'll give you the reference, or I'll send you across the paper. Thank you.